الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Thank you, Mr. Chairman, ladies and gentlemen. It's a pleasure to talk about rhythm control. Let me say I have a huge conflict of interest before I start, because we do ablation for a living. So I think this is a huge conflict of interest to put me on a debate whether rate control is better than rhythm control. We do rhythm control in our hospital. We don't do rate control. I'm an electrophysiologist from Jeddah Military Hospital. So AFib, I think you all know that AFib is a huge burden to the society. It carries morbidities and mortalities. It increased the incidence of stroke fivefold, and the stroke associated with atrial fibrillation is usually catastrophic, results in more morbidity and more mortality. Also, strokes related to atrial fibrillation is usually recurrent, unlike other type of strokes. If you ask any clinician, or if you ask not a cardiologist about rate versus rhythm control, I'm sure everybody will mention the landmark trial, AFFIRM and RACE, New England Journal of Medicine articles. So my aim for today, and this is my take-home messages today, that those are obsolete trials. They were done basically before the era of AFib ablation. I don't think the results conclusion would be applicable nowadays, given the widespread use of ablations worldwide. And I would hope that by the end of my talk, you would understand what I mean. The AFFIRM and RACE trials showed that the embolic events occurred in both groups, whether you aim for rate control or rhythm control, at the same rate. So basically the conclusion of the AFFIRM and RACE that there is no overall advantage of rate over rhythm control. However, I don't think this is 100% accurate, and I will tell you why. In both trials, actually, they allowed to stop anticoagulation, and that definitely resulted in more thromboembolic risk. Why you get more thromboembolic risk is because you lose the organized atrial contraction and atrial fibrillation, and also you would definitely increase the ventricular rate if you allow the heart rate to go to a higher level, and this leads to immediate and long-term adverse consequences. If you increase the rate, if you lose the atrial contraction, you will have deleterious effects on hemodynamics, and you lose the AV synchrony. And this probably will result more and more on atrial and ventricular dysfunction. But we all agree that rate rhythm controls improve symptoms, but neither has been conclusively shown to improve survival. However, with the exception of one trial, which showed that if you treat atrial fibrillation early, you would potentially improve the survival. And this was published in the East AF trials. There are at least 3 reasons why failure of rhythm control reduce the embolic risk. And I would go over, I know the slide is busy, but I will go over the things very quickly. Despite successful cardioversion and antiarrhythmic, the recurrence rate of either paroxysmal or persistent is 35 to 60% at 1 year, and may increase to 88% with continuous monitoring. So basically, the failure of rhythm control not related to the failure of the strategy. It's related to failure of the medication that were used in the AFFIRM and rhythm trials. Also, the AFFIRM trial showed crossover, and when in any study, when you see crossover between the two arms, you start to wonder about the result of the study. And we all know that most of the AFib recurrences are asymptomatic. Actually, in one study, up to 90% of AFib recurrences were asymptomatic. Also, 40% of patients had symptoms which appear to be AFib, but it's not related to atrial fibrillation. And we all also know that even brief episode, up to 5 minutes episode of atrial fibrillation, could result in a 6-fold increase of the risk of stroke. So the duration, even 5 minutes is enough actually to increase your risk of strokes. One other thing is not all strokes in patient with atrial fibrillation are related to left atrial appendage clot. It could be related to carotid disease or apical clot, not necessarily related to atrial fibrillation. Studies, similar studies have shown similar efficacy between the rate and rhythm control. These studies showed equivalent outcomes when it comes to death or embolism in both arms. But most of the studies that you get showed that you get most symptomatic relief with rhythm control strategies. However, there is one study that I have just mentioned earlier, that if you diagnose atrial fibrillation early, if you ablate it early, you would potentially get survival benefit and also with the rhythm control arm. Here are the limitations of the AFFIRM and RACE trials. The AFFIRM and RACE enrolled old patients, so that's number one. So you cannot generalize the study on young patients. So the mean age was 70 and 68 in the studies. So I don't think it's fair to generalize those studies in younger patient populations. Also, half of the patients in the AFFIRM had minimal symptoms. So not only elderly, but it also have minimal symptoms, less than 1 per month. If you happen to see a young patient with atrial fibrillation, definitely he will wake up from sleep having symptoms. So it's not a rare minimal symptoms for young patient. So in real life, a patient have more frequent symptoms compared to the AFFIRM and RACE trials. Also, the use of antiarrhythmic therapy in both the AFFIRM and RACE trials might not be benign. I have always said in many podiums, in many conferences, that antiarrhythmic are poisons. I've said this many times. I'm sure you heard it from me several times. And I think only electrophysiologists should deal with those poisons because they know how to titrate the dose and they know what to expect. The incidence of proarrhythmia with sotalol is 6%. So imagine we do cath and we tell the patient there is 1% risk of death. So using sotalol and without knowing what the risk involved is not something good. And there are many studies which show that if you use those antiarrhythmics in patients with structural heart disease, you actually increase mortality. So I think it should be used only by electrophysiologists. So the bad effect, the bad result from the affirm and race, or the equivalent result from the affirm and race, may be related to the increased mortality from the medications, not necessarily related that the rate control is good. Maybe the poisons that you give to the patient are bad. So one interpretation of the data that maintenance of silent rhythm might be beneficial if you have a safer antiarrhythmic or a safer approach like ablations. Also, most importantly, the affirm and race were done before the era of ablation. So basically in an old era, where AFib ablation was extremely difficult. It was done over 5 hours when I was a fellow, and it was done point by point. So now we have this cryo, it takes 20 minutes. We have PFA. I did one PFA last week. It took me 15 minutes to do the whole case. So it is a different era. So I don't think generalizing a 5-hour procedure result to a 15-minute procedure result. So basically, it's not fair. So I think catheter ablation is much safer than antiarrhythmic, using antiarrhythmic drugs. So one other thing's major caveat is that both trials allowed for cessation of anticoagulation after documentation of sinus rhythm, which is absolutely wrong. So those are the trials. I'm sure everybody are familiar with the result. One important trial that I need to mention, for the first time, actually, this trial showed that you have mortality benefit with rhythm control. The only comment, my personal comment of this is, you have to treat early. So the inclusion criteria of this study showed that the AFib should be detected and treated and ablated, and the strategy of rhythm control should be done very early. So for the median time for AFib in the race was a year, while the median time for the E study was 36 days. Basically, this is what we do in the military hospital in Jeddah. Once we get AFib, we ablate. So that's not because we are rushing things and we do things against the guideline. Now we have evidence that actually if you ablate early, within 36 days, you get actually survival benefit. So when do you prefer rhythm control over rate control? Of course, the EAST trials. If you have a similar patient where you have high-risk patient with high CHA2DS2-VASc score, with your high morbidities, high risk factors, I don't want to go over the inclusion criteria because the take-home message of this presentation, you get an overall information. You are not, and some of you are electrophysiologists, but most of you are a general cardiologist. So any patient with high comorbidities, I think within 36 days should be referred for ablation based on the study. Also, a patient with a failed rate control strategy definitely would be eligible for rhythm controls. Patient with symptoms, palpitation, dyspnea, angina, syncope, all these are good legitimate reasons for ablation. Inability to attain adequate rate control. You put the patient on a beta blocker, calcium channel blocker, and the heart rate still 110, 120, and the patient is feeling fatigue, hypotensive. This is a very good reason for ablation. Heart failure actually is a class 1 indication for rhythm control strategy, especially ablation. It's a class 1 level of evidence A. I will show you the guideline when you have heart failure, or of course if you have young patients. So basically, heart failure is a is mandatory reason for ablation, in my opinion. So the debate is when you are in a military, I'm biased with the military hospital. So if you are in a tertiary hospital, do you think you would go for a rate control? I would definitely not. I would see using a rate control strategy if you are in a primary care clinic or if in a remote area as a bridge. But if you are in a tertiary hospital, I don't see why we go for the rhythm control strategy, because the rate control strategy is universal. You need a beta blocker. You don't need advanced EP lab or anything. And it's widely available, very low cost. But if you're in a hospital already and you have all the equipment, I don't understand why people go for a rate control strategies. As I mentioned before, most of the antiarrhythmics are bad. So this is another take-home messages that are bad. You should not use them. I think once you think of antiarrhythmic therapy, you should refer for either ablation or refer for antiarrhythmic use by the expert. This is the guideline. This is not just my recommendation. This is the guideline. So basically, if you have paroxysmal or persistent, you talk to the patient. Sorry, I don't have a pointer. You talk to the patient. You go for ablation. Okay? Rhythm control, not rate control. Okay? If you have patient with major risk factors for recurrence, patient choice, you go for ablation. This is not me. This is the guideline, by the way. So I don't need to prove anything more than this slide. If you go there, persistent AFib without major risk factor, you talk to the patient, you go for ablation again. So let's go for the last thing, paroxysmal AFib, you go for ablation. So all of them leads you eventually to ablation. So this is a consensus opinion, widely distributed document that unfortunately not adopted by most of the cardiologists in the kingdom. This is also class 1 indication. So I don't want to go over more literature and more data if you have a consensus opinion of all the experts. So in summary, the decision regarding rhythm or rate control should be made after discussion with the patient, showing the benefits and risk of each approach. For symptomatic patient, rhythm control. There is no rate control, okay? For many symptomatic patients, especially with a high risk of cardiovascular events, especially if it's diagnosed early, the rhythm control, there is no rate control. The only rate control, in my opinion, strategy should be advised in a patient in more than age of 80, because patient more than 80, they are more sensitive to proarrhythmias. They don't tolerate antiarrhythmics, and AFib most of the time is permanent. So I showed in the guideline paroxysmal persistent, but if it's permanent, then definitely rate control is indicated. And also the fact that most of the patients above 80, they have asymptomatic episode. Thank you.